right, I have the honor to introduce 3 people to you today. Maybe wave when I say your name. So first we have Barbara Ochsner, LMFT. She's worked for 35 years as a life coach, social coach, and surrogate partner. She recently received licensure for marriage and family therapy, and her internship work resulted in certification in gerontological wellness. She currently volunteers at the Institute on Aging in San Francisco and offers mental health counseling with individuals and families, as well as continuing her work as a life and social coach. Barbara. Next is Annie Chen, LMFT. She's worked with individuals, couples, and organizations around sexuality for over 10 years. She's been a supporter and advocate of using surrogate partner therapy to address sexual issues in various settings, including long-term care facilities and private practice. She primarily works with couples in her private practice, and her research focuses around using neuroscience to help people have better relationships. Annie. And Cheryl Cohen Greene. DHS, lecturer and author, has been in private clinical practice as a surrogate partner since 1973 and is the vice president of the International Professional Surrogates Association. You might know that as IPSA. Cohen Greene is a frequent media guest and lecturer. Her work with poet-journalist Mark O'Brien inspired the award-winning 2012 independent film The Sessions. Her book, An Intimate Life, Sex, Love, and My Journey as a Surrogate Partner, a memoir, was published in January 2013. Cheryl. Thank you all for being here.
Hi, everyone. Thank you so much for coming out in the rain. I appreciate it so much. So today we're going to be talking about, how as therapists to work with a surrogate partner. And so we're going to, hopefully by the end of the presentation, you'll walk away and you'll know, what is surrogate partner therapy. You'll have an understanding of what you need to know about sex in order to be effective at surrogate partner therapy. Some clinical considerations around SPT, the therapist-surrogate collaboration, which is at the heart of SPT, and we'll see a video of the work that was made by CNN, actually, and then we'll talk a little bit about law and ethics. So I just want to say that we're all really excited to be here. I was trained in this work by these 2 lovely ladies who combined have, over 80 years experience. So I'm just really honored to be standing up here today with both of you. And also to say to those in the audience that without you, therapists, SPT would go away. Therapists are the ones that refer clients to surrogate partners and keep this work alive. And then on the resource page that is on the tables and also on the chairs, you can look at a little bit about the research and the studies that have happened over the years, over the last 50 years plus, about the efficacy of SPT. And of course, we could always use more studies and more research in this matter, but there's a good start there. So so I wanted to just break down a little bit. If you could have a show of hands in the audience, so we can make our presentation better for y'all. Just raise your hands if you've worked with a surrogate partner. Yeah, okay, so we have 1 person in the room, yeah. And if you have ever thought it would be useful to work this way with a client, to involve a surrogate partner, wow, okay, awesome. It's like almost about a third or half of the room. And who has never considered before today the option of working with a surrogate partner? Okay, yeah, it's about a quarter of the room or so. Okay, okay. So I want to break down now what is surrogate partner therapy. maybe you've heard a little bit about it in media. Maybe you've seen Cheryl, the movie that was based on Cheryl's work, The Sessions. But basically, the way that I like to explain this is that as therapists, what our ultimate goal is to help clients do better in their lives and to help them heal from the obstacles that are in their way to live a more fulfilling life. And so much of that healing is done in relationship. Um, and, and, and at the same time, there are certain kinds of relationships, certain kinds of intimacy that we don't have with our clients. Sexual intimacy, physical intimacy, certain kinds of social intimacy. And so we can guide them and we can provide, the information or, practice kind of some of these skills with them in kind of in a removed way, in a distant kind of removed way. And then we hope that they go out there and they find somebody that they like and is suitable for them to practice these skills, and so that they can actually have those experiences that transform, what they believe is possible or what they believe is true about themselves. And so this part about we hope that they go out there and they find that right person. Sometimes, because of the obstacles that clients are experiencing, or because of just sheer luck, they don't always, right? Or we for years they might not. So at this point, as therapists, what if we could work in partnership with somebody who's really trained to offer this experience, in an ethical way to clients, so that we know they're doing this with the right person and that they're getting a great experience. Does that make sense? Yeah? Okay. Some nods. And so this is what surrogate partner therapy is about, and we're here today to break that down a little bit, so that you can all feel more empowered to take further steps into doing this work. And Cheryl, can you tell us a little bit? Cheryl, you've been a surrogate partner for 47 years. Can you tell us a little bit about your understanding and a little bit about the history and the triad relationship?
Hi. When I started working as a surrogate in 1973, it was because I had gone through years, and you'll hear this accent, so please try to understand what I'm saying. I had grown up in Salem, Massachusetts, in a French-Canadian Catholic family. And there was no talk at that point, no sex education in school, lots of don't touch yourself down there, and shame. Just a lot of shame and guilt. Going to confession was probably one of the worst things I had to do. In fact, my last confession was a priest said to me, "It's girls like you that ruin young boys' lives." And when I asked him, what about my life, he had no answer for me. And that was it. I left. I wasn't going to go through that anymore. When I got to Berkeley in 1968, I found out that there was a Sexual Freedom League, and I didn't join, but I found out all these things were happening. I also met a woman who was a surrogate partner, and she was fantastic. She was kind enough. A friend of mine gave me the book Surrogate Wife. I read that. It was very interesting. I later found out from Bill Masters, who I got permission to call him Bill, said to me, yeah, she did work with us, and a couple of the clients were not she made up to make the book more juicy. Well, there was no need for that, as you probably can guess. So what I did was I got involved with San Francisco Sex Information because there was no training. There was no IPSA then. IPSA was in the birthing process in '73. And I took the training, and I loved it. And I learned I had huge amount of judgments, which blew me away because I didn't know I was judgmental. And I am. I think everybody has their judgments, so they didn't wipe it away. But I opened my mind and heart to so many different sexual lifestyles. And that was part of my first training. And then I went and met two therapists. Bernie Affelbaum was one of them, and if anybody remembers Bernie. And then I met a man who, Tom Durkin. He's no longer in practice in the Bay Area anymore, but he took me to, he wanted to work with me. Bernie had 4 other women working with him. He didn't need another surrogate, so I wound up working with Tom, which was fantastic. He took me to a course that was run by Tom and Thea Lowry. They had been one of the first 5 couples to go to Masters and Johnson to learn how to do conjoint therapy, and you all know what that was. 2 therapists for one for the male, female. It was heterosexually oriented kind of therapy. I wound up working with him. Taking this course blew me away, and I worked at San Francisco Sex Information for 20 years. I got on the training staff in my 2nd year there, and I loved it. I still think of it as a great process for anybody who wants to open up their minds and they do trainings all the time. A lot of therapists do that, take their training. I started working then, and I'm still working now, but so many changes have happened over the years. Not so much with the client's concerns that they bring into therapy, but so many things have been added by Hartman and Fithian. They put together the sexological. That's a part of the 4th session, looking at each other's genitals. By the time we get to that, we've established lots of intimacy with just basic touch. Surrogate work is a gradual increase of intimacy, and we go at the client's pace. I always tell clients when they call me up that when we meet, we're going to go it's a process, but if there's anything that you're not comfortable with, we stop. Now, I only work with therapists, and if you're an IPSA, I was the vice president. I just figured that was too much. I've been the vice president for years, so I've retired, so I wanted to correct that idea. But the whole process is based on wiping away or helping people wipe away the misinformation they grew up with. How many kids, I mean myself included, had their parents talk to them and tell them, honey, it's okay to masturbate? I know that feels good. I do that too. Just the living room is not the place to do it. Come into your bedroom. I mean, I had to tell my daughter this, and I said, you're distracting me. My husband said, be honest with her. And I made a nice little spot for her so she'd be comfortable. But how many of us grew up like that? We didn't. Clients come to me all the time. Nobody talks to them about sex, their parents. I brought a book with me too, Changing Bodies, Changing Lives. It's a great book to refer to parents for teenagers. It's the big one. I should have pulled it out. It's fabulous. And I think it's in its 3rd edition, but it's by the people that put together the Women's Health Collective in Boston. Our bodies, ourselves. So I think my chiropractor just gave her 11-year-old this book. She said, he's asking me questions. I said, read it, so you'll be on the same page, or the 2 of you can go through it together. But the work I do is not work. I am not a therapist. I am a surrogate partner. I've been trained. I know I had one of the best trainings in the world, the people that I mentioned before. Now I've been with IPSA for many, many years, over 30. I cannot do the things. I will not work with clients. In the 70s, therapists would say, let me know how things work out. Well, they didn't work out. I'm just not the therapist. You're not supposed to be. If you were a therapist doing this work, you'd get in trouble. So what I want therapists to understand is people now, because of the book I wrote in the movie, The Sessions, and the Netflix, that's another thing that you might want to check out on Netflix, the 40-Year-Old Virgins. It's me working with a man and a male surrogate working with a woman. And I think that shows my work much better than The Sessions did. I mean, The Sessions was wonderful because it gave a voice to people with disability and their desires and feelings, and wonderful movie that way. But I feel like the therapist has to understand, we're not here to take your clients away. People used to say that I'm afraid the surrogate's going to wind up taking my client. No, any legitimate surrogate who is certified and has gone through and I feel IPSA's training is the best, has gone through IPSA. And you have to get certified after you've worked with several clients, and you have a mentor. I'm a mentor for a lot of new surrogates. And you work with a therapist who is also a member of IPSA, although there are therapists who aren't, that I still refer people to, who I know well over the years. That's it. It's a triad. You work as a team, and I explain that to the clients. So the work is dynamic. The best thing about it is you see somebody's face when they walk in the door, and you see them after the sessions. I work with people between 8 and 14 sessions. If you went to Masters and Johnson in the old days, you were there for 2 weeks if you went with your partner. And I did a statistical analysis when I got my doctorate, and it had to do with how many people benefited from the work, and about 88%. The rest of the people that didn't were people who came in, had no idea that this was a process. I mean, the therapists tell the clients we're not going to be intimate sexually. It's a gradual increase of intimacy, but people don't listen. And those people were surprised that they were going to have work to do. And those people who stayed, maybe everything they thought they were going to accomplish while they were there isn't accomplished, but nobody's ever said, I really feel bad about what we did. Because we're really working on changing, helping people grow, helping people accept their own bodies. I work with women now as well as men. And I've had a mastectomy. I've had things happen to me in my life. And my sexuality didn't disappear. And I'm 73 years old, and my sexuality hasn't disappeared. It's changed, but we can adapt. And that's what our process is about, helping people open their hearts to themselves. Yes. Oh, I have worked with couples. In fact, I'm working with a couple next week. I love working with couples. Mostly it's about teaching them how to relax with each other, how to go back to the things that attracted them to one another, help them do that. I also work with women, when we get a call from the therapist and it's a married person, I'm going to address this right away because that happens sometimes. And the partner has said, you go get fixed. There's something wrong with you. Well, the therapist and I both say to that person, will your partner come with you? I won't work with them. You don't have to work with me if your partner wants to do this with you. Somebody's designated as the problem, and it's not a problem, all their problem. So we address that, and the partner would say to me, listen, I want to know if I'm okay. Some things, I haven't been functioning correctly, and usually it's because they need to learn how to be nicer to each other, how to resolve some unresolved issues, all of those things. So if they find out that they're okay, I said, the therapist and I both say, then there might be time at that point for the couple to work together if the marriage or the relationship and whatever it is going to work. So we don't say, yes, come on in, we'll hide this from your wife. There's a contract that you're all going to be getting too that'll explain one of the things that we can do that help both parties and how that all works. But yeah, the process, I think I addressed it just now, didn't I? My brain just went numb. This aging thing. Yeah, we're going to take a lot of questions later. Okay.
So we thought it'd be fun to do a role play, and so Cheryl and Barb, maybe we could have you seated in the. Or you're over there. Maybe that's okay. So we thought it'd be fun to do a role play because in the triad relationship between the therapist, the surrogate, and the client, the communication between the surrogate partner and the therapist is so crucial, and it's such at the heart of the therapeutic work and getting the feedback that the therapist needs to go and do more work with the client. So we thought we would model this through a role play, and so in this role play, Barbara, you're going to be the therapist, and Cheryl, you're going to be the surrogate partner, and the two of them are working with Phil. So he's a 45-year-old male, and he's working with the therapist and surrogate partner to address problems getting and maintaining erections. So this is somewhat of a common issue. And so the role play takes place, this is after the fourth session between Cheryl and Phil. And then by this time, they've really developed a relationship, as Cheryl said, that is based on increasing intimacy over time, and to really growing an authentic relationship based on communication, based on safety, and based on exploration. So take it away.
Hi, Barbara.
Hi, Cheryl. Good to hear from you.
Yeah, I had an interesting experience today with Phil.
Tell me about it.
We were doing the sexological, and he was going first. And I was in the process of exploring his genitals, the right, the left side, down the middle, getting feedback from him. And then I put the condom on him, and I went down on him with my mouth. And he said, "Oh my God, it doesn't hurt."
Wow.
And I said, "Really? Does it usually hurt?" He's, as you know, he's in a relationship with a partner, a girlfriend. So I said to him, "Okay, so it hurts when she goes down on you. What can you explain a little bit about what happens?" He says, "Well, I can feel her teeth scraping along my penis." And I said to him, "So you've never said anything to her?" Right. And he said, "No, I haven't said anything to her. I don't want to upset her. I don't want to ruin the experience."
So
I
what
said,
we have here is a communication issue.
Yes, what we have here is a failure to communicate. And I just said to him, "Okay, well, what you need to do is, this is important. If, I can show you different ways that I could stimulate your, touch your penis with my hands or with my mouth, my lips." And I did some of that with him. And he said, "Yeah, that all feels good too." So I said, "Okay, well, this is something we need to, you're paying me, you're paying the therapist, and this is something I'm so happy that came up right now because we have the
That's
reason
great.
for, there's something we can do about this."
Beautiful.
So what do you think?
I think it's great.
Okay.
So let's both work with him on increasing his communication skills.
Yes, and I want to do more role plays with him on how to do that.
Great.
Okay.
When Cheryl talks about his girlfriend, this is a prior girlfriend. So this is somebody who was unpartnered at the time.
No, he was actually still seeing her.
Oh, okay.
There was room to work here.
Okay, Barbara.
What am I doing?
Okay.
So
Oh, we want to. No, I can do
I'm
it, Annie.
curious.
I'm up. I could do it.
Okay.
So what we'd like to do is get some feedback from you all about how you felt about that conversation. Cheryl being so direct and using sexual language, and because it's really important for us as therapists to be able to do that, to be able to talk with our clients, have a language to do that, not clam up if they say something that makes us uncomfortable. So does anybody want to share how they responded to that?
I love it. I like it being clear and open and free like that. And so many, I hear stories all the time when I hear stories all the time when I see clients. They come to me asking, "How do I feel talking about sex?" And I say, "Oh, I love talking about sex." But they have had experiences where people don't want to talk about it, how to do it, what to do, what's going on, therapists.
Yes.
So I love the openness. Thank you.
Yeah, I think it's critical. If we're going to be able to, if we're going to do this, we have to be able to talk about it. Somebody else raised their, oh yes.
Yeah, we're going to use the microphone for the recording.
My first response was a slight jolt of the directness, and then delight of the freedom of that.
Yeah. So for those of us who are, did anybody else want to share anything? For those of us who are uncomfortable, we want to, did we have that slide going, Annie? Oh yeah, so we just have some resources here that are ways to maybe, for you all to address issues that you have about it, discomfort about talking about sexuality. Yes?
It just occurred to me talking with a recent client I started with, she didn't even come to me on sexual issues. But she's a little bit older. She's talking to me just lamenting about how she has low sex energy some days. And she's shocked, she was totally shocked because I just barreled right into it like, hey, let's start talking about different ways you can have sex with him that you don't have to do the traditional. And after a while, a couple sessions of that, she's going, oh my God, I never believed I'd ever talk about sex and be comfortable with it with my therapist. So we can do it and not shock our clients.
It's so important. So just, we just have some things listed here to, possible resources with anyone who feels like they need to do that. And I did a little internet research to look for things that might assist us in identifying, helping clients identify. So if you do a Google search, we have so these were some of the things I came up with, and you'll get this. To just find questionnaires that help the client and you identify what's going on with them so you know what you're addressing.
And also, to mention that a few resources that we really like a lot, there's some training. So local SFISI training, San Francisco Sex Information Training is great.
Cheryl?
O School is online. It's o.school. And it's free, and you can just take classes, online classes that cover a range of topics around human sexuality. And there's also a book that Cheryl has over there, and it's called
Great.
What Every Mental Health Professional Needs to Know About Sex by Stephanie Bueller.
Yeah.
And we recommend that one a lot as well.
Can you hold that up?
Oh, yeah.
Want to take a picture? Yeah, I want to take a picture.
Who's the author, Cheryl?
I can't pronounce, how do you pronounce that? Bueller.
Bueller.
Stephanie Bueller. It's not that hard.
And this is also in the PowerPoint that you'll get. So it's up there, the title and the name. What's that?
You're saying we're going to get the PowerPoint.
Yes, yes. So the question was the PowerPoint. Where is the PowerPoint available? We will make it available to you, so we'll send it to the event organizers. Yes, and Joe over there. It'll be online. It'll be online. That's what I'm being told. Okay.
But question, will it be online separate from the video?
You're up now, sweetie.
Question was, will it be online separate from the video? And the answer is yes. Yes, it will.
Can you go back to the resource? Is the sex therapy survey something for us to give our clients?
Yes.
And what's the main words in there? The WordPress thing?
Yeah, it's hard to read on the screen because it's bright in here, but it will be legible in the PowerPoint. So you can go online wherever the RECAMFT website is hosting this PowerPoint, and you can get this exact PowerPoint. And is this also on the resource page, Barbara, that we sent out and
No.
is on the? No, it's
not.
Okay. Okay, so some of these are online self-assessment questionnaires. If the client feels more comfortable doing it at home, to just get a better idea of what kind of things they can and should think about and talk about around their sexuality. That's helpful. And some of them are more for therapists to go over with the client, or just to use as a resource to learn what to ask and how to ask. Okay. Okay. So Cheryl, can you tell us a little bit about who you work with?
Who's appropriate? You notice I put this down there? No social, please.
I think you need the mic.
Oh, good. Thank you. Thanks. Late in life virgins. I just finished working with a man who was 76 years old. He came in for an intensive from Washington. Oh, God. I was just thinking, Washington, what a place. Medical disability, either congenital at birth or caused by an illness. I work with people, a lot of men who've gone through prostate surgeries, who are worried that they're not going to be able to function and explore. We do the same process, the gradual increase of intimacy with them, too. It helps everybody to go slower, as we all probably know. Social communication disorders. I work with mostly men who are in the spectrum, the autism spectrum. Behavioral and personal defenses that push people away from them. Yeah, hygiene is one. I work with men on, you see that little streak on my sheet? That wasn't there before. But I do it gently. I do it lovingly. No, seriously, you can't beat somebody up and have them and then have them feel sexy anymore. So, we can deal with everything. Then abuse and trauma. I had this client years ago that was when I touched his face during the first session, and I do a whole body touch. It's non-sexual, but it's so that he can learn or she can learn to accept touch. And he started to cry, and he told me that he never had his face touched like that, except his mother slapped him in the face all the time. So his therapist didn't know this. And these things come up in the process with me. I found a man with a lump on his testicle. It was testicular cancer. And he had noticed it but ignored it. So, you know, I told the therapist, and as a triad, we worked with him, and he's still alive today. Difficulty getting and or maintaining erection, that's classic. A lot of it has to do with lousy communication between people. Trying to have sex when you're pissed. Yeah, when you're pissed. You're not happy, things aren't going well, and then your partner expects you to just ignore all that because he or she is horny. Difficulty getting in on painting, I just said that one, right? And no sociopaths. I actually had a man come to me who was a sex offender. I opened the door, he was referred, and I saw this person. I immediately, I got that feeling he was very strange, and he was abusing a child who was 4 years old, right, not at that moment, obviously, but he was telling me things, and I pulled my SFSI training out, and I said, oh yeah, okay, is there any more you want to tell me about that? And he told me a lot, and I called the therapist, and I was trying to see if I could do sensual touch with him. I just stopped dead in the middle. I sat on the bed, we were both naked, and I'm thinking, what am I going to do when he realizes he's going to have to go back to jail when I tell the therapist? And I had all these thoughts in my head, and the whole time I was doing it, I was asking, okay, is there any more you want to tell me? So when I got him, I said, well, you know, I think we're ready to stop the session right now. And, you know, you're not ready for certain things. I'll talk to your therapist, and made it just a light thing. And he got ready and left, and I closed the door, locked it, and called her. And she was shocked. And I said, do I call the police or do you? And she said, I'm doing that right now, right after I get off the phone with you. So it's not a joke. I mean, really evaluate the people who are sent to a surrogate, whether they're appropriate or not. And that's that. Yeah.
Like you just said, okay, you're naked. I didn't know that. You know, just like, okay, typical session, maybe progression of sessions. Yeah. You know, like you said, you start out with touch. You know how intimate you get, how you're dressed, just so I know if I refer someone to you, exactly what's going on.
I'll do that quickly. I know that's important to know. Oh, okay. We're gonna be seeing the video, and the young woman her approach is for a particular kind of client, and each client is different. So. In the 40-Year-Old Virgins, if you watch that on Netflix, he and I didn't get undressed together for several sessions. In a lot of time, I'll give people options, and if they don't want to get undressed, I say, that's perfectly okay. We'll go at your pace. So we do a hand caress, or a face caress, or a arm caress. We sit on the couch and we do that. With people who are virgins, I will do more of that, who have never held hands, never kissed, never been touched, you know, hugged. They may have been hugged, but not in a sensual way. But often we go into the bedroom, we get undressed, and when I work, I don't dress to, you know, be attractive. I dress like I always dress. I dress like this, you know, or whatever reasonable facsimile. I don't set up a little love nest, but I do have my apartment and the bedding, and I have music. I like the Liquid Mind CDs. I play those. They inform my hands when I'm touching a person. If we do go in and get undressed, I've had a mastectomy, so I introduce them to Sally. This is Sally, my breast. If you watched The Nightmare Before Christmas, you'll know who Sally was in that. She's the doll that fell apart. And we lie down, we do breathing and relaxation. I notice shoulders, I ask them to drop them, and all of that. And we do spoon breathing. And then we get into feedback. I do one side of the person's body, the back side usually, because it's less vulnerable than the front. And then the client will roll over and we'll do the next part of the body. I always check in and tell them if you're feeling anxious and I notice a tight area, I'm going to ask you to breathe into it and relax. So it's getting them, introducing them to their own bodies.
And the title for this is Sensate Focus
It-
exercise, which
this
is, I think,
sensate
important
focus,
for you
being
all to know.
aware of yourself. You know, people will do things till they're in pain, or you know, if you're giving somebody oral sex, I was going to say, well, you know, we're all adults, a blowjob. You know, I've done it in the past when I wasn't a surrogate, where I was dying, and then I started resenting the person. And that's not okay. It's up to me to communicate what I need. So the whole process is teaching clients how to communicate in every situation. So I do that. Second session, we do revisit the touch. I get touched in that session. I give feedback about how I like to be touched before, and if they're rapidly touching me, they're anxious, I stop for a minute and I ask them to give me their arm and I'll show them. I like long, slow touches. It's all therapeutic, but it's not like Swedish massage, and they want to learn that part of it too. Then in the next session, I stand in front of a mirror. We always greet each other in the living room. We always check in, how are you doing? How did you feel about last session? All that kind of stuff. And I've already talked to the therapist before each session. So then we go in and we we both get naked. We sit on the bed. We do a little breathing if the client needs a little of that, and I can tell when they do. And I stand there and I talk about my body, how I felt when I was a child, how I feel now. I even share about my waddle, you know. I just say, yeah, I don't like this, you know. And I wish I had my breast back, but I don't. So, you know, this is good to have. It balances me out. And then they get up, and before they start, they usually say to me, well, you know so much about, you do this all the time. And I said, yeah, well, just start at the top of your head. Usually the people that say that to me are up there for a good hour telling me things. They remember stuff from way back, you know, when I was a kid, I felt this way, that way. All of this is going to the therapist. When I get off the phone, when the session ends with the client, I call the therapist before that client sees the therapist again. I explain every detail. It's important, every detail. The reason we did that thing about the part about are you comfortable with talking and giving feedback, explicit, it's very important to me, because I would talk to some therapists and they'd say, okay, Cheryl, thank you. And I would just feel like, oh my God, this is all important stuff. I was taught in the Masters and Johnson modality, and it was, don't leave anything out, really give details. So I do. And then that session, when they do the mirror exercise, the next session is the sexological. It's called the sexological, but all of that kind of contact and body awareness is sexological. But we do the specific one where the client sits with their back against lots of pillows and make them really comfortable. Their legs are over mine. And I'm exploring with my hands dry, and then I've used some lubricant. Then I use my mouth. We're always using safer sex. So I introduce them to condoms if they've never used them before, how they can be fun. They're not a demon that you don't want to use because you're going to lose all your sensation. It's attitude. It's what's going on in their heads. So I explain all that to them. The next session after that, that's a very telling session too. We see what happens with, I don't expect everybody to get an erection, but if a person doesn't get even the slightest anticipation, scariness, then the fourth session, the fifth session is we become more intimate. We haven't kissed yet. And that's an important one, finding out how a person kisses and how, you know, if they need, I always check their fingernails and do all that and from the very first session, because they're going to be touching me and I want their hands clean. I ask people to wash their hands before we start every session. And it's stuff like that. That session, the fifth session, we don't have intercourse, but if they're getting erections, we want them to go away. And we want them to come back again, and we want the client to know why they went away, what thoughts or anxieties were coming up. It's really an amazing process. And, you know, I have to like the person. I don't work with people I feel have a bad attitude about me or about the process. Why are they there? You know, they really want to they have to want to do this for themselves. So, does that help? Very much so. Oh, good, good. Sure, please.
I feel like I need, it's coming up really strong.
No, well, please.
I've worked in forensic. Hi, this is coming up real strong for me right now. And thank you for that presentation. I've worked in the forensic population, and I've met quite a few sociopaths. And it's taken me many, many, many years to recognize that. And I feel there's such a vulnerability. I mean, coming into your own home, I just need to, I just have a concern about, especially young, not so much maybe with the training. However, I just want to put it out there.
Are you concerned about the surrogate or
Yeah, this surrogate that might not have the life experience that you have, that invites a sociopath into their home and can't.
I had no idea I was inviting a sociopath.
Oh, no, but I mean, I know there's a lot more. I know several.
Okay, well, I was a much younger. I wasn't a teenager, but I was in the first few years of my practice, and I started when I was 29. So it was, it was one of those things. And I have found out through my whole life that attitude is everything. If I had appeared scared, and I tell that when I'm talking to young people who want to do surrogate work, if you find yourself frightened, and they sense it, people sense it. No, you don't have to be a sociopath to see it. Yeah.
I've worked with a couple of surrogates, and it's the responsibility of the therapist to assess that before referring. And actually, are they appropriate? That's part of the assessment process.
Yes, thank you.
Thank you. We're also going to have a Q&A at the end. Is this really urgent now, or okay? We're going to do a Q&A at the end. We really want to take your questions. Just need to say something. Okay.
I just want to say that as a therapist, I always do a disclosure at the beginning of my therapy. And one of the things I say is if there is child abuse, that I would have to report it. And so otherwise, it would seem as though it was sort of an entrapment, that if your therapist that you were working with this gentleman that you described, did not, in fact, disclose that up front to the gentleman who you had to turn into the police, then they would not have told you that. So I'm curious about that. Am I making myself clear?
Yes, you are. And Annie wants to address that.
I think I want to say absolutely, that part of informed consent when, as a therapist working with a client, we all know this, is the limits of confidentiality. And so I don't want to go into the specifics about that particular situation that you brought up.
Okay. I would address this. She did tell me that he had just gotten out of prison for child molestation, and that he was in a program trying to find out whether he was capable of dealing with an adult woman. And I knew that. I did not know, I have never met, and I hope I never do meet somebody like this man again. There was something, I just met one. I met him, and he was scary. And I'm not saying that I don't know what the therapist's experience of him was in her office. It was surprising. We never worked together again after that.
Mm-hmm.
I have no idea what happened after I called him. I would assume that she was going to call the therapist, call the police.